Okay, which of the following is the most likely underlying cause of the patient's syncope? The patient is 55-year-old, is brought to the emergency department after collapsing at a grocery store and losing consciousness for 1 minute following a death, following a sudden onset of palpitation. He has no chest pain or dizziness. He has a history of hypertension, type 2 diabetes mellitus, and he is currently being treated as an outpatient for pneumonia. This is important. His current medications are lisinopril, metformin, and azithromycin. So they're asking all the other normal examination is normal. So telemetry shows polymorphic ventricular tachycardia with cyclic alteration of QRS axis, which spontaneously resolves after 30 seconds. So some drug in the listed drugs is causing polymorphic ventricular tachycardia and cyclic alteration. This is torsades, right? Some drug is causing this. Which of the following is most likely underlying cause of patient syncope? You have to choose what is the cause of this torsades. It is prolonged QT interval. Okay, now which of the following is the underlying cause of patient syncope? Now, as we read before, the patient is having pneumonia. That is the important part, and he's taking azithromycin, which is causing a condition with polymorphic ventricular tachycardia with cyclic alteration of QRS complex. This is torsades. Can anyone tell me quickly what are the other drugs causing torsades? Which is basically prolonged QT interval. This is the straight away stuff. What other antibiotic? Azithromycin is a macrolide, right? Macrolide. What other antibiotic causes torsades? Torsades is the ECG looks like this. The ECG is like this. This is torsades. Wide QRS complex, right? See, the QRS complex is so wide. What are the other drugs causing this? Class 1 antiarrhythmic drug, class 1A, then fluoroquinolones, and class dofetilide. Dofetilide is class 3 antiarrhythmic, right? Haloperidol, which is class 1 antipsychotic. These are the important drugs causing torsades, which is a wide QRS complex condition. Okay. Now, if we go down, we know prolonged QT interval is can be congenital or acquired. What is the congenital condition? Romano-Ward syndrome, is it? Romano-Ward syndrome. Romano, it's there in first aid. Okay. Then typically remains asymptomatic until the patient presents with syncope. Obviously, if the heart is not pumping properly, the brain is not getting blood, so there is syncope. Then life-threatening arrhythmia, which is called as torsades. Acquired QT prolongation is because of certain drugs that I mentioned, macrolides and fluoroquinolones, and antiarrhythmics like dofetilide and tricyclic antidepressant. This patient's history of azithromycin therapy suggests that drug-induced QT prolongation, and the patient is most likely to have torsades and resulting syncope. Now, torsades can be due to decrease in calcium, decrease in potassium, decrease in magnesium. Right? These can cause torsades. But our patient is not having any of these symptoms. The decreased magnesium can cause muscle weakness, decreased potassium can cause muscle weakness, and potassium also has impact on ECG findings, right? Hyperkalemia can cause peak T waves. T waves will be peaked. Hypokalemia will have depressed T waves, right? Our patient doesn't have any of these ECG findings. As we know, he had only polymorphic and cyclic QRS complex, right? That's it. Now, Hypomagnesemia will cause torsitive ones, but our patient doesn't have neuromuscular manifestations like tetany, seizures, muscular weakness. Brugada syndrome is inherited disorder. I told you before, it causes ST elevation in V1, V2. Our patient doesn't have that, right? And fast accessory conduction pathway is with WPW syndrome. Can anyone, I will close this. Can anyone tell me what is the ECG finding in WPW syndrome? Important ECG finding in WPW syndrome. It is an accessory pathway, right? Which bypasses the slow firing AV node, right? It quickly sends signals to ventricle bypassing AV node. What is the ECG finding? Can anyone tell? What is the wave called in WPW syndrome? What wave is seen? Okay, to see there is delta wave. Okay, this is P wave. There is delta wave. P wave. This is delta wave. See, there is a slant in the QRS complex. This is delta wave. This is seen in WPW syndrome. So because of this, normally QRS complex should be like this, right? Because of this, PR interval is early. So there is shortening of PR interval, right? So what are the two important ECG findings in WPW syndrome? There is shortening of PR interval and there is delta wave. Okay. Now let's see. Fast accessory conduction pathway, WPW syndrome, will have palpitation and syncope. All these arrhythmias, all these tachyarrhythmia, bradyarrhythmia, will have palpitation and syncope because the heart is not pumping and there is no blood to the brain. So they will have dizziness, syncope, all these sequelae. As seen in the patient, however, typical ECG finding, shortened PR interval, as I told, slurring and slow raise in the initial upstroke of QRS complex, which is called delta wave. Okay, and obviously because of the delta wave, it will have widened QRS complex. Normal wave will be like this. Because of the delta wave, you will have widened QRS complex. Okay. Now, what does hyperkalemia? As I told, it will have widened QRS complex and it will have peak T waves. Peak T waves will be there. Okay. Obviously, hyperkalemia will have muscle weakness, malaise, and palpitation.
Thanks for watching. Please give a thumbs up and subscribe for more.